Good afternoon. Thank you so much for inviting me to be a part of your program. My name is Allie Deering Anderson, and I am a faculty member at the University of Nebraska College of Pharmacy. If after the program is over, you want to contact me, this would be the best way. Yes, you can probably Google and find my office phone. Here's the catch: I never answer it. So you can send me an email and I will get to it just as quickly as I am able. If it's an emergency, don't send an email, because obviously right now I'm talking to you, so I'm not checking email. I am a member of the faculty at the University of Nebraska College of Pharmacy. Thank you, by the way. When you pay your taxes, it helps support the University of Nebraska and my position, and I really, really like that. My husband, my children, and I have a company that does some consulting, but nothing that would be in conflict with this particular program. I do have to tell you that I do not take money from drug industry, and in this case, it probably won't matter. We're going to talk about groups of drugs, but probably not any specific drugs. I hope when we're done chatting that we will be able to describe some of the challenges, particularly for older folks, but not necessarily, that happen when we have polypharmacy. And maybe we will learn what the word means. We're going to talk about how to ask questions of your pharmacist. One of my challenges, and you'll hear me say this again, I don't know what you don't know. So we need to find a way to ask those questions that can help me understand what I can do to best help you. And certainly the ultimate goal is that you are able to help yourself, the folks that you serve, the people that you love, be more active in participating with making pharmacotherapy decisions. We have some fun pharmacy facts, and I think sometimes if we start with those, that we begin to understand how big a problem we could have, and then certainly some of the ways that we could solve that. The estimates are that people who don't follow instruction cost the healthcare system about $300 billion every year. And that's certainly not just wasted drug. That is a disease that gets worse because the drugs aren't taken. A patient who ends up in the hospital because they forgot to take something or they were unable to take it and we didn't understand. Amazingly, 20 to 30% of all prescription written are never picked up. That means the patient took the time to go see the nurse practitioner, the physician assistant, the doctor, the dentist. That professional wrote a prescription and it never got picked up. So that means that only 70 to 80% of the prescriptions that are written actually get home with the patient. And then half of them are taken incorrectly within the first 2 weeks. And that may include, oops, I forgot a dose because I slept in on Sunday morning. Or it may include something that is much more difficult for us to manage. 20% of all hospitalizations might be related to drug non-adherence, not following the instructions. And that does not include being behind on or not being vaccinated. Okay, so this is just prescriptions that the patients have taken home with them. If we could include those people who didn't get their vaccine for whatever reason, then we would add in things like pneumonia and influenza. Shingles very rarely results in a hospitalization, but when it does, it can be tragic. We still have tetanus and diphtheria and pertussis in the United States. And so those vaccines being missed or delayed or ignored can also be a problem. So we could actually get this number much closer to 30% if we added in all drugs, including vaccine. When we look at more facts, about 7,000 Americans will start to abuse some prescription medicine today and tomorrow and the day after that. And the abuse means taking more than was prescribed, taking somebody else's medication, or taking that medication for a purpose for which it was not intended. So we're not just talking about opiates, although we're probably talking a lot about opiates. Every 15 to 17 minutes, an American will die from a prescription drug overdose. Some of those, very sadly, will be on purpose. Others of them will be a situation where their substance use disorder has gotten so big that the dose it takes for them to get whatever feeling it is that they are looking for, and the dose that takes to kill them, is the same dose. In the United States, we are less than 5% of the world's total population, and we take 95% of the world's hydrocodone. We don't have more pain in the United States than they have anywhere else. But we're doing something very different than the whole world. Part of it is our opiate crisis, but part of it is we actually treat patients differently. And we need to look at that in order to help ourselves, to help the folks that we care for, and certainly the folks that we love. So there are a number of ways that we can improve adherence. Yeah, the data shows us that about 75% of all Americans do not take their medication as prescribed. So there are some things that we can do to improve that number, but what we cannot do is know why. Why do 3 out of 4 people not take their medication correctly? Let's look at some of the things that we can do. We can do medication simplification, and I'm going to show you a couple of items. We can do some memory packaging. We can talk about synchronizing refills. And then we can maybe identify those 3 out of 4 who aren't taking things correctly, and perhaps individually figure out what we can do to help them best. That's on the pharmacy side. The other ones, we can actually bring in our community colleagues to say, I think that this is needed. When we look at medication simplification, in the old days, it was I had 2 drugs. I had capsule 1 and capsule 2. And then the drug industry found a way to combine those drugs into a single tablet or capsule. Sometimes medication simplification is as easy as, can I take all these at the same time? Line up 5 or 6 or 12 bottles and take 1 dose out of each and just swallow them all with a lot of water. The other thing we can do for medication simplification is identify those drugs that aren't really treating the patient. They're treating a side effect of another drug. Sometimes that's absolutely essential, particularly when we are dealing with mental health situations. Some of those drugs, in order to control mental health, cause us some side effects that we just need to treat. But other times, if we change the first drug, the problem drug, we can get rid of the second one because the side effect is gone, so the need to treat the side effect is gone. Who are our best candidates as you are thinking about family members, friends, the clients that you work with? Anybody taking 5 or more doses a day. Now, it may be the same drug 3 times, but those get counted individually. Patients with memory difficulties, especially patients with Alzheimer's or Alzheimer's-like disease, because remember, they often wake up fairly lucid. It's as the day progresses that they run into trouble. So if I can move everything to morning and lunch, they will be lucid and able to care for themselves much longer, avoiding those doses that occur at or after sundown when things begin to get a little bit difficult. Travelers, people who travel for recreation or for business frequently, especially those people who go through a multitude of time zones. When we're thinking about, I take whatever it is every morning at 7, and I wake up in London. Do I take it at 7 London time? Or do I try to do the math to figure out what time it is in Nebraska? Or how do I manage those things? Those are patients who need to have their medications simplified. Parents or grandparents of children with hectic schedules. You have to get the oldest one to soccer practice, and then you're going to go from there immediately to the dance practice, and then you have to swing by and pick up the kid who just got done with band. And that tuba has to fit in the trunk so that you can get back and pick up the youngster at dance practice, and then we're going to strap both of them in the back seat because they have seat belts that fit them. Then we'll pick up the oldest one from soccer practice who now has to ride in the front seat, and all that smelly soccer stuff that has to go in the back, but it can't sit right on top of the tuba. And you want me to remember to take my drugs too? That becomes so difficult. Patients who have part-time caregivers. Clearly, we do best when we can move those meds into that time frame when the part-time person will be there. So it's great if they come in every day from noon until 4. I can move those. But if part-time means they come in on Monday and Thursday, I don't have many drugs that I can only dose on Monday and Thursday. Usually what I have gets dosed at least once a day. Now we're going to look at a couple where that's not true, but for the most part, the management of our chronic diseases requires a dose of something once a day or more. So we need to work to get as many doses as possible timed so that there is somebody there to help. I will also tell you that 8 a.m. is not magic. Not all meds have to be taken the first thing in the morning. So timing simplification, and we talked a little bit about that, can be magical. It feels amazing for the patient and the people who are worried about the patient and the pharmacist when it works. But it doesn't have to be first thing in the morning. If you or a loved one or a client sleeps in, I don't want to time things so that they feel like they have to get up. I want to make it work in their world, because then I have truly simplified things, but I have also increased my chance that I can change that 3 in 4 who are unable to take their medication correctly. These happen to be pictures of a thyroid supplement. This one's difficult. People who take a thyroid supplement must take it on an empty stomach. So we always advise that you take it the first thing when you wake up. Again, I don't care if you wake up at 6 a.m. or if you wake up at noon. I want you to take this immediately when you wake up. Your stomach will be as empty as it gets all day long. This drug cannot be taken with any others. In fact, I have to wait about 45 minutes to an hour. So when I do the timing on this one, I'm going to have at least 2 times of the day when the patient has to take medication. immediately upon waking, and then some other time that's at least an hour later. Sadly, however, not everyone taking this drug knew that. So they have faithfully been taking it with breakfast for 3 or 4 or 5 years. And this drug gets dosed on blood levels. I can't have those patients changing immediately to taking it on an empty stomach because their blood levels change and the effect of the drug changes. I may impact their sleep. I may impact their ability to tolerate temperature. So I have to be really careful, even in medication simplification, that I don't cause a problem that didn't exist before. We have binding agents. We think about things like Questran that is used to bind cholesterol. We think about Miralax that is used to bind water to help with constipation. It's also used to bind water to help with some patients who have chronic diarrhea. What we don't always think about is that if it can bind cholesterol and it can bind water, it can bind any other drug that's in your belly at the same time. So these we have to separate by at least 2 hours. And you understand that medication simplification isn't always simple. We're going to work really hard on it. But for some patients, they may still have 3, sometimes 4 dosing times a day. That could be an improvement over the 6 they have now, but I can't promise that it will all be in one fell swoop. The bisphosphonates are one of those drugs that you do not have to take every day. Some of them you do, some of them you don't. They have to be 45 minutes before anything else except water. And then the patient has to stay upright. They have to sit up straight, they have to stand up straight for 45 minutes. So you can already see that we've talked about a drug, the thyroid. And now we're talking about a second drug, the bisphosphonate. And the thyroid wants your stomach to be empty, and the bisphosphonate always wins. So what you would do for this particular patient is you would say, immediately upon waking, take the bisphosphonate. Then sit up or stand up for 45 minutes. Then take the thyroid. Then wait another 45 minutes before you have breakfast. That's an hour and a half. And I can't let you go back and lie down because the bisphosphonate burns the bottom of your esophagus. So you have to say sitting up or standing up. And you can understand quickly that what we really want to do for that patient is do our very best to change one of those drugs. Because I can't wait an hour and a half after I wake up to have my first cup of coffee and breakfast. Most patients cannot wait an hour and a half after they wake up to start their day and to get some things rolling. So we need to be very careful with how we time drugs. Stuff that most folks never think about. But then think about if I tried to put it on one of those little tiny labels that has your name and my address and the doctor's name and the number of refills and the day you got it filled and the instructions, how would I ever type all of that onto one of those little bitty labels? So we end up with a challenge in I don't know when you're having trouble because you have to tell me this dosing thing is not working. I can't wait an hour and a half. Or worse, I have chosen not to wait an hour and a half. So neither one of these drugs that I am paying for and taking is working because I end up throwing food on top of them and that messes up our system. The other thing that we have found in pharmacy is that somehow when I give you a brand name drug and I warn you about side effects or I warn you about timing, that not all patients understand that the generic is going to have exactly the same warnings and exactly the same timing. Because of course, for the brand name, they may have seen a commercial on television. For the generic, they never did. And so they are aware that the warning exists. They're just not aware that the warning goes with the drug. Doesn't matter who made it. The warning goes with the drug. There's actually some places where timing, the healthcare system doesn't agree, like statins. We think in pharmacy primarily, all statins should be taken when you go to bed, unless you are a shift worker. Then we want you to take them between 10 p.m. and midnight, even though you are going to be awake. Now there are those who say it doesn't matter quite so much. If I have to give you a statin to protect your heart, I want it to do the best job possible. Valacyclovir, if you've ever taken it, you will remember they are very big, dark blue tablets. They are the tablets that we use to treat shingles, and occasionally we use to treat cold sores. They work better with a high-fat meal. And it's amazing to be standing at the pharmacy counter and say to the patient, this is going to work best if you take it with a real milkshake or a cheeseburger. And they always look at you a little funny, like, are you serious? And the answer is yes. Or you can run to this particular county fair and have deep fried butter or chocolate covered bacon. All of those things, the high fat actually makes the drug work better. And we need to be able to tell you about that. Indomethacin, a drug that we use to treat pain. We use it to treat joint pain, arthritis pain, gout pain. It has to be taken with food. Lots and lots and lots of food. Because with this drug, if it touches the lining of your stomach, it causes upset stomach and it can cause damage. Indomethacin, because of this and a couple of other problems, including it makes your body hold a little extra water, has been on the Beers list from the very beginning. Dr. Beers and all of the colleagues that he has worked with through the years and the folks who have continued the project are geriatricians. They specialize in treating people 65 years of age and older, and they actually create and update a list of drugs that are probably too dangerous to be given to people over the age of 65. So if you or one of the folks you are caring for or about is over 65 and taking Indomethacin, I'm going to warn you that there are people who think that we need to find a new drug simply because of the patient's age. All of those things roll in to medication simplification and good messaging. Zolpidem. Zolpidem is the generic name for Ambien, a drug that helps us go to sleep. And the problem with this one is we've got some folks who take it for too long. But that's not the problem that I'm the most worried about when I'm talking about avoiding problems and making that simple. My problem is, where do you store this? The bed and the drug cannot be in the same room. And the reason is you will take one dose, you will doze off, you will awaken for whatever reason. The neighbor kid came home and the car stereo was too loud. The dog barked. There was an amazing thunderstorm and the lightning and the thunder crashed and you woke up. And you will think, because you are in that phase, I bet I didn't take my drug. And if it's in the bedroom, you will take it again. And we actually have a number of reports of patients who have overdosed because they would fall asleep for a little bit, wake up, take a dose, fall asleep for a little bit, forget that they have taken the first dose, they're awake, the drug is supposed to put them to sleep, and take another and another. So we have to be sure that this one does not get stored in the sleeping area. Certainly memory packaging is another way that we can help people remember to take their drugs. $300 billion gets wasted in healthcare when patients can't take their drugs correctly. And there are all kinds of memory packs. Some of them are easy to open, some of them are hard to open. Some of them make perfect sense if you can take everything on Sunday morning at that magic 8 a.m. Others of them, it's nice to be able to take out Sunday, drop it in your handbag or your backpack, and go do whatever it is you're gonna do on Sunday. And always have your drugs with you. Some of them are so bulky that you couldn't do that. When we look at refill synchronization, it has a very specific process. The patient will go to the pharmacy that supplies refill synchronization, the technician will explain to the patient what's going on and say, may we sign you up? Then 5 days before all of your refills are supposed to come due, the technician will call and verify, we're going to fill these 5 days from now. Are you still taking everything that's on this list? And you have 4 drugs. 3 of them are fine, 1 of them is out of refills. It gives me 5 days to call the doctor and get refills on that last prescription so that I can fill them all on the same day. You only have to come to the pharmacy once. You pick them all up on the same day. It allows me to talk to you about all of your medication at one time. It allows me to plan ahead, and we're going to look at some of that. And the pharmacy can make adjustments for drugs that get started or stopped in the middle of that. You always get things refilled on the 1st of the month. That's your chosen day. And you get something new started on the 14th. Probably I will only give you 16 days that first time, so that it will come due for refills with everything else that we fill on the 1st of the month. Those are the kinds of things that we are able to do. Do I think that's magic? You know, I don't know that I think it's magic because I've looked behind the curtain, right? I know how it works. I know what the theory is. But for a number of patients, it must feel magic. I can call the doctor when you run out of refills and you don't have to wait for that. I can identify non-adherence. Oh yes, I still take 5 things, but I only need 4 of them refilled. Why? Why am I not filling that 5th? The other thing it can do, frankly, from running a business is if I know 5 days from now that you need drug X, I can order drug X so that it is there. And you should get many fewer messages about, well, you know, we only gave you 5 and we're waiting for the order to come in, or we don't have any, or we have called around and nobody has any. But the other thing I can do when I know you are coming is I can check for things that I should also do for you. Is it time for you to get a vaccine? Have you had the complete medication review that Medicare will pay for? Do I need to work on the timing of that? Is there a disease that I should be screening or monitoring? And I can plan all of those things with medication synchronization because I know that you are coming in. And some of you are thinking, okay, this is cool and I'm going to look into MedSync or memory packaging, but why wouldn't people just follow the directions? Well, there are lots of reasons that people don't follow directions. The first one is they're very confusing. Every night before food, once daily to be taken 4 times a day, 3 times a day, every 3 times daily. That's a real label that sadly got out of a pharmacy. The bottom one I'm not going to read to you, but you can understand how odd that must have seemed to the patient. I would suspect that that bottom one was so weird that the patient said, "You want me to do, huh?" Sometimes it is forgetfulness. Sometimes patients who don't take their medications as instructed don't do it on purpose because they don't like the side effects. The side effects are terrible. And they would rather, they think, have the disease. Instead of coming in and saying, "Pick a different drug. This is awful," they just don't take it. And there are some patients who get the prescription, buy the prescription, and then decide, I don't think this is the right thing for me. I'm not convinced it's going to be helpful, so they just don't take it. So there's lots and lots of reasons why you wouldn't follow instructions. And then we look at polypharmacy, and that really means more than one drug a day. Although you can think of lots of people who take a multiple vitamin and one thing for hypertension or high blood pressure. Most of those are not the people we are talking about. The people we are talking about is when we're taking more than one drug for the same condition, or we have lots of chronic conditions. It can get expensive, and some people do have to choose, which one am I going to buy? It can be very confusing, especially if you can't remember which drug is for which thing. They can have additive side effects. And certainly if you're taking more than one thing, there's a chance for a drug-to-drug interaction. So there are some really important questions we need to ask our pharmacists. What is this for? Is there a way that I can tell if it's working? Now, if I'm taking something for my blood pressure and I don't monitor my blood pressure, probably no. There is no way that I'll know if it's working until somebody else takes my blood pressure. When should I call you? The patient should ask the pharmacist, what can go wrong? When should I call you? Well, call me if you get dizzy, call me if you get a rash, but you need to ask those questions because I don't know what you don't know. Is there a special time of day I should take this? Did you check? Does it interact with anything else that I am already taking? Even if you don't fill it, in Nebraska, there is a list of every prescription filled for you for about the last 2 years. So I can look and make sure that it doesn't interact with anything else. Does it interact with food? Does it interact with alcohol? Does it matter if I am using over-the-counter drugs, if I'm using supplements, if I'm using medical marijuana? Do any of those things change this drug? I love it when patients ask me, even if they ask me all those questions, right? My technician can count out the tablets and prepare the labels. This is what I'm a pharmacist for. And we've got some legal quirks that make things a little bit difficult. You have heard about HIPAA, the Health Insurance Portability and Accountability Act, that says I can't tell other people about your medication. But it only applies to me, not you. If you are worried about a child or a spouse or someone in your church, and you want me to know something about their health, you may tell me. I can't always answer, but I can always accept that information and I will work with it. In Nebraska, there is a mandatory offer for patient counseling. Every time you pick up a prescription or somebody mails you a prescription, they have to give you a free way to ask questions. All of those questions that we listed before. And we do have the Prescription Drug Monitoring Program, PDMP. That's that electronic database of all prescriptions that get filled for patients who live in Nebraska. We have some other laws coming, some debates in Congress. Certainly, if you have any questions, feel free to call in, send us an email. If we can't get to it right this minute, we will get to it. But let's think about some of the other things that are going on. There are folks who want us to be able to import drugs from outside of the country in hopes that they will be less expensive. I suspect your insurance won't pay for them. So they would have to be a lot less expensive to actually save you money. There are certainly people who are still discussing, what are we going to do with this opiate problem? And sadly, we have some places where we are not treating pain in the same way that we used to. I don't think we have a lot of patients writhing in pain, but it takes longer to get those things done. And remember, no legislator said, I want to hurt a patient. That was never what this is about. It's an attempt to make things better when it is so complicated that I'm not sure that we can. There's always going to be somebody arguing about Medicare and what it should cover and who should be eligible, and whether it is what drug shall it cover, what service shall it cover, who shall it cover. Certainly between now and November of 2020, we're going to hear 9,000 different proposals for healthcare. What I think is helpful is if you don't understand how it might impact you, talk to the people who are caring for you. I can tell you what some of those proposals would do in a pharmacy. Some would be fabulous, some not so much. I'm never going to tell you who to vote for. That's one of the cool things about being an American. But I can certainly tell you what impact it might have on you and your finances and your health. So I think I'm going to stop now and we'll answer any questions that there may be. And it looks like we have one.
In nursing homes, the medication aides are probably well versed in, telling patients when to take the medications, how to take them. But someone living at home, is it really up to the caregivers? And how do you educate the caregivers?
The fascinating question about timing. And she makes a great point. She says in nursing homes, the medication aides and actually the pharmacist decide at exactly which time every medication is given. And they're labeled that way. But what happens when somebody is living in the community or even in assisted living but taking their own drugs? Who decides the timing on that? And I suggest that most patients do that for themselves. But we could help if you would ask at the pharmacy counter, help me figure out what time to take all of these things. That was one of our early suggestions for helping people get things done. My goal is always to have a sort of morning lunch dosing time when you can take most things. And then perhaps a bedtime time when you can take the rest. For some patients, we have to spread it out more than that. Think about caring for your diabetic patients who do some things before meals to prepare to consume some sugar and some things after meals to manage the fact that they did just compare sugar. But certainly talking to the pharmacist, just making us aware that figuring out what time to take things is a challenge gives us enough of a heads up that we can help manage that for you or the people that you are caring for, right? If you just tell me, I have a client who is taking these 4 drugs, what time of day shall we schedule those? Can she take them all together? I can answer those questions, and I'm happy to answer those questions. And perhaps not only can we help the patient remember to take them, but we can actually get better results from the drugs. Great question, thank you.